Hello, and welcome to the 2013 ClaimCare CPT coding update for cardiology. The following information is the sole property of Cardiology Billing Partners, a ClaimCare company, and may not be copied or used without the express written consent of ClaimCare Incorporated. All coding changes discussed are in accordance with AMA CPT 4 coding updates as of February 5th, 2013. Any additional or future changes will be addressed in a future release. Our speaker today is Ms. Sandra Renfro. Sandra is the Quality Assurance Manager for Cardiology Billing Partners, a ClaimCare company. As such, she routinely performs charge coding audits to ensure compliance in accordance with state and federal mandates. Sandra is a certified coder with a special focus on cardiology billing. Thank you for joining us today, and we hope that the information reviewed will assist you in attaining all of your practice's goals in 2013. With no further ado, Sandra.
Hi, Susan. Thank you. And welcome to the cardiology code changes for 2013. And needless to say, there are major changes to cardiology again for this year. We have new ventricular assist device codes, intracardiac electrophysiology ablations, new TAVR or TAVI codes, which is the transaortic valve replacement or insertion. We have percutaneous coronary interventions, the PCI services. Sorry about that. Okay. We'll begin with the percutaneous ventricular assist device codes. We have 33990, which is the insertion of ventricular assist device arterial access, including radiological supervision and interpretation. 33991 is both arterial and venous access with a transseptal puncture. 33992 is the removal of the percutaneous ventricular assist device. 33993 is repositioning of the ventricular device with imaging guidance. Additionally, you can report services for the open arterial exposures, the 34812. You can also code the replacement of the artery access, 35226 or 35286. Just a couple of billing guidelines on here. Insertion is based on the site access. The replacement of the ventricular access device is reported with the insertion codes. Removal is included when an insertion is done in the same session. Repositioning is also included when done in the same session as the insertion. Next, we're going to the cardiac electrophysiology ablation codes. These new codes better describe the procedures, and they include the diagnostic study. There are 5 new codes for ablation techniques. First one, we have 93653, which is a comprehensive EP study with ablation for treatment of supraventricular arrhythmias. This service includes the induction or attempted induction in an arrhythmia, right atrial pacing and recording, right ventricular pacing and recording, HIF bundle reporting, and supraventricular ablation. If any of the above are left off, you would report the modifier 52 for the reduced services. The next code we have is the 93654, comprehensive EP study with ablation for ventricular tachycardia or ventricular ectopy. These services include the induction or the attempted induction in an arrhythmia, right atrial pacing and recording, right ventricular pacing and recording, the VT ablation, 3D mapping when performed, and left ventricular pacing and recording when performed. The third code we have in this group is the 93656, which is a comprehensive EP study with ablation and treatment of atrial fibrillation by pulmonary vein isolation. The services in this include the transseptal catheterization, multiple, induction or attempted induction of an arrhythmia, atrial pacing and recording, this is right or left, right ventricular pacing and recording, hip bundle recording, and the pulmonary vein isolation. The next code we have is an add-on ablation. It's the intracardiac catheter ablation of a discrete mechanism of arrhythmia distinct from the primary ablated mechanism. You would report this for each additional along with the 93653, the 54, and the 56, the comprehensive study. The next add-on would be the 93657, intracardiac catheter ablation of left or right atrium for treatment of atrial fibrillation remaining after pulmonary vein isolation, each additional. You would report this code with the 93656 when pulmonary vein isolation is successful and further ablation of the mechanism is performed. For additional reportable services, you can report the standard mapping, 3D mapping, left ventricular pacing, program stimulation, pacing after the IV infusion. Bundled EP studies with transcatheter ablations. Examples, supraventricular EP study with an ablation. In 2012, you billed the 93651 and the 93520. In 2013, you would use the 93653. The atrial fibrillation EP studies with ablations. In 2012, you billed the 93651 and the 93620. 2013, you would use the comprehensive study code of 93656. Continuing with the VP studies with the ablations, 2012, you billed the 93652 and the 93620. 2013, you would use the code 93654. 93651 and 93652 have been deleted. Next, we're going to discuss the transcatheter aortic valve replacement or insertion procedures. Here we have 9 new codes that are reportable for these procedures this year. We have 33361, percutaneous femoral artery approach, the 33362, the femoral open artery approach, the 33363, the open axillary approach, the 64, the open iliac, the 65 is the transaortic approach, the median sternotomy, or the media sternotomy. Sorry about that. The 0381T is transapical approach, which is the left thoracotomy. The 33367 the cardiopulmonary bypass percutaneous peripheral. The 68 is the cardiopulmonary bypass open peripheral. The 69 cardiopulmonary bypass with the central arterial. These services include the access, valvoplasty, deployment, temporary pacemaker, the closures, and the radiological supervision and interpretation. When billing these codes, Medicare would expect to see several things on this claim. You're going to need the 62 modifier, which is reporting the 2 surgeons. They expect an interventional The place of service should be reported using 21, inpatient, and the Q0 modifier, alerting Medicare that this patient is in a clinical study. Those 3 items must be on the claims in order for it to pay. If not, it will be denied with reason codes like a 58 for modifier not consistent with CPT and others. Additional reportable services would be diagnostic angiographies, cardiopulmonary bypasses, balloon pumps, ventricular access device, other percutaneous procedures done in the same session. Next, we're going into the percutaneous coronary interventions. You may ask yourselves on this, what changed? Well, we no longer have just the regular stent codes. We have 6 stent angioplasty atherectomy codes were deleted. We have 13 new codes that were created. Major coronary arteries are predefined, and there's more specific codes for the intervention. The major vessels this year, Medicare has recognized that there are 2 more. We now have the left main and the ramus are now recognized as main vessels. So instead of 3, we have 5. We have the LAD, the left circumflex, right coronary, left main, and the ramus intermediate. All interventions in a major vessel are reported with 1 percutaneous coronary intervention code. Interventions in up to 2 branches of each major vessel can be reported with the add-on code. The 13 new reportable intervention codes for the PCIs, we have 92920, which is the balloon angioplasty alone. The 92921 is for each additional branch. 92924 is atherectomy. Again, a standalone procedure. The 92925 for each additional branch. 92928, stent alone. 92929 for each additional. The 92933, the atherectomy with a stent. The 92934, atherectomy and stent for each additional branch. The 37 is the PCI of or through a bypass. The 92938 is the PCI of or through bypass for each additional branch. The 92941, PCI of acute MI, all interventions. The 92943 is chronic total occlusions. The 92944, chronic total occlusions of each branch. And all of these include balloon angioplasty when performed. On the add-on codes, if you'll notice on the Medicare fee schedule, they do not have a fee for that. Medicare will not pay for the add-on codes, but the other carriers may, so you would have to, set your fee and then bill it out. There are some guidelines on reporting for multiple lesion procedures. You would report only 1 base code for each major coronary artery approach. You want to report the most intensive service performed in that vessel. We have a hierarchy that comes into play here. You have the acute total occlusion. That's higher than the chronic total occlusion, is higher than an atherectomy plus a stent, is higher than the atherectomy without a stent, which is higher than just a stent. Any services through a bypass graft is higher than the balloon angioplasty alone. Kind of a tongue twister on that one. You can report up to 2 add-on codes for services and branches of each coronary artery approached. report as add-on code the most intensive service performed. Example, you have your chronic total occlusion and your bypass graft is higher than the atherectomy and stent, which is higher than the atherectomy without a stent, which is higher than a stent, and a stent is higher than a balloon angioplasty alone. The acute myocardial infarctions, the 92941, includes all services performed at all sites in that vessel. The 92973, mechanical thrombectomy, may be reported separately. Catheter aspiration thrombectomy is not reported separately. There are some things to remember. When billing these codes, diagnostic angiography at the time of the intervention is reported separately when the following occurs. There was no prior catheter-based angiography was available, and a full diagnostic study is performed, and the decision to intervene is based on those results. Or a prior study is available, but the patient's condition has changed since that study was done. You had inadequate visualization of the anatomy, or there was a clinical change during the procedure that needs a new evaluation outside of the target area. All percutaneous coronary interventions include contrast injections, angiography, road mapping, fluoroscopic guidance, the vessel measurements, and any post-intervention angiography. And don't forget the imaging add-on codes if you did them. You have your intravascular ultrasound, your Dopplers, mechanical thrombectomy, and spectroscopy. Can't talk today. You also have your intravascular optical coherence tomography. And that is quite a bit, with those stent procedures. Next, we have our cervicocerebral angiography, 36221. It's a non-selective catheter placement thoracic aorta with angiography of the extracranial carotid, vertebral, and or intracranial vessels, unilateral or a bilateral study. The 36222 is a selective catheter placement, common or innominate artery, with angiography of the ipsilateral extracranial carotid, circulation, unilateral, any approach. 36223, selective catheter placement, common carotid, innominate artery with angiography of the ipsilateral intracranial carotid circulation, unilateral, any approach. 36224, selective catheter placement, internal carotid artery with angiography of the ipsilateral intracranial carotid circulation, unilateral. 36225, we have selective catheter placement subclavian or innominate artery with angiography of the ipsilateral vertebral circulation, unilateral. The 226, selective catheter placement vertebral artery with angiography of the ipsilateral vertebral circulation, unilateral. The 227 is a selective catheter placement external carotid artery with angiography of the ipsilateral external carotid circulation, unilateral. The 228 is cath placement each intracranial branch of the internal carotid or vertebral arteries with angiography of vessel circulation, unilateral study. All those services include radiological supervision and interpretation, and angiography of the cervicocerebral arch when performed. Cannot bill those separately. Next, the thrombolysis. Billing for the thrombolysis, we have the 3722211, the initial day, inpatient stay, 3722212, the venous thrombolysis is initial day. The 37213 is arterial or venous subsequent day. The 37214 is stopped. This is your final day. So you'd be able to bill the 37211 for arterial thrombolysis the first day they were in the inpatient setting. If you're going in there the next day, it's your subsequent visit, which is going to be the 37213, the arterial or the venous thrombolysis. So when you stop those services, you would bill the 37214. That's your final billing day for that. Codes are now reported based on the type of vessel and the stage or episode of treatment. Separate session on same day is no longer billable, so you can't have one physician in the same group going in there, doing a thrombolysis that morning and another one that afternoon. You can only bill it one time per day. These services include angiography and conscious sedation. There has been a lot of changes, again, for 2013, and we can't be too careful as billers. Be sure to check the revised wording in the CPT manual, as some of that has changed as well. The word physician has been removed from the descriptors of some of the CPT codes to now read other qualified healthcare professionals. And this is the end of the code changes for 2013. There's a lot more changes out there that will affect each and every biller and coder out there. So again, just be sure to read your updates, your pink sheets, or the Medicare Learning Network is a great resource as well. But also, if you have any questions, please give me a call, or you can email, and that information will be forthcoming. So I do thank you.
Thank you very much, Sandra, for providing us with this much-needed update and recommendations. If anyone has any questions, you may direct them to sandra.renfro, that's SANDRA.RENFRO @claimcare.net, or you may contact Susan Price and Sheila Michael. You can also visit us on the website at www.claimcare.net. We hope that you all have a very profitable and successful year. Bye-bye.